So I'm actually filling in for Asher Chen and Khan as well, and I am going to do both together. Hopefully I won't get confused. So chemotherapy-based regimens, they still have a role in untreated CLL. And then we're going to talk about the Ibrutinib-based regimens as well. So I always like to start off with this series of slides looking at how we've been doing over time. And this is not purely meant to be a surrogate for what was and what is. But certainly we've talked about many times the evolution of therapies over time. So this is a slide from Michael Keating that really shows the differences in survival of CLL patients based upon the decade that they were diagnosed. And you can see that we go from 1980s all the way up to the 2000 decade. And clearly it looks like we're doing much, much better. But there really needs to be a huge caveat with this. And that is that when you look at stage for stage survival, there's actually no improvement in survival for the Benét stage A and B patients. And this is a European study, and that's why we switched from Rye stage to Benét stage. But so there's no benefit in over time with the improvement, there's been no improvement in survival over time when we look at the Benét A and B stage patients, but there is a small improvement in the Benét C patients. So the vast majority of the improvements that we see in the curve really relate, or the curves from Dr. Keating probably relate more to lead time bias in the early diagnosis of patients. And what you can see here is from the same study in Europe, looking at the percentage of patients diagnosed with Benét stage A in the 70s, 80s, and 90s. You can see that the diagnosis of CLL in Benét stage A increased from 26.3% in the 1970s to 72%. And you can see the associated improvement in survival that was associated with that. So we still have this benefit in Benét stage C, and perhaps that is due to better supportive therapies. Maybe this is the beginning of clinical trials and the advancement of new agents, and that will eventually translate into more later on. So you can see here the evolution of therapies over time. Of course, starting off with the alkylators and now moving into the tyrosine kinase and small molecule inhibitors. So I've combined them all into this new terminology, TKIs and SMIs. And what I really want to emphasize, as I mentioned earlier, is over time, we've certainly had a dramatic improvement in CRs and overall responses, and we have very good data supporting those as endpoints for patients doing better. And I believe that a CR, even with a tyrosine kinase inhibitor, or a kinase inhibitor rather, is better than a PR, but really it's still a question as to when do you look. And so, right now we don't know what the CR rates are because that's going to evolve over time, and we see PR rates of 70 to 100%. And so we really need to, once again, obviously try to get the best responses possible, but not be discouraged with our patients having PRs, because the ultimate key for our patients is overall survival, and the next best probably progression-free survival. So currently FDA approved therapies, and in a way I always like to, before I talk about this, apologize, and I don't need to apologize to all of you, but apologize to often the patients when I talk about what are FDA approved therapies and why they're FDA approved and why they're not. And it's really sort of a crazy system that we have here in the United States, where drugs have to either be proven better or they have to actually be an unmet medical need. And there's certainly been a move away from the unmet medical need indication, with really ofatumumab being the last agent approved in 2009 for an unmet medical need. And it's also important to remember that safety is not an approvable basis. So we can't say, gee, these agents are great. I mean, look at these kinase inhibitors and how well they are. They have no toxicities, because that's just not an approvable basis. And what they have to do is do better than chemotherapy. And of course, an FCR trial is such a long trial that it's really going to be a distinct disadvantage to our patients to actually hold off on getting the approval of these new agents if we were to do that type of trial. So going through the approved agents and regimens, one is, of course, Chlorambucil, which is grandfathered in, Fludarabine was originally approved as a single agent in 1991, alemtuzumab in 2001 for fludarabine refractory CLL, and then in 2007 upfront, Bendamustine in 2008, ofatumumab in 2009, and actually again in 2014 upfront, FCR in 2010, obinutuzumab in 2013, Ibrutinib in 2014 for CLL, and idelalisib in 2014 as well. But there are many non-FDA approved standard regimens, and certainly there's a large number of people out there receiving pentostatin-based regimens, fludarabine Rituxan, bendamustine Rituxan, high-dose methylprednisolone plus Rituxan, R-CHOP, and RCVP. And, you know, going on the basis that FCR is sort of the current king, and it certainly is, if you were to ask most physicians in the United States at least, FCR is the standard of care for patients who could tolerate it. So looking at progression-free survival and overall survival, and these once again are data from Dr. Keating, one of the things that they love to actually remark on is when you look at the progression-free survival, we have a very nice plateau here between 30 and 40%. And this, of course, you know, looking out is, you know, here we go out to almost beyond 10 years, and it really starts at about year 10. So we're really talking about very, very long times that people are going without relapsing. And the question is whether or not we can call these people cured. Now, one of the huge caveats with that type of statement is that this population of patients here are enriched for the mutated patients. So we're talking about the good patients, or the good prognostic patients doing well. But still, it would be nice to say with 6 months of therapy, you can be done and not have to get any other additional therapies for a very long time. And ultimately, this is really where our prognostic markers are going to be playing such a key role. If we could really figure out who those people are, the flip side, of course, is knowing that there's always going to be a downside to those patients getting FCR, and I'll talk later to the fact that 7 to 8% of these patients who should have been in that population aren't in that population because they developed MDS and AML as secondary myeloid neoplasias. So when we look at the FCR-treated population from MD Anderson by survival, by age, you can see once again that certainly younger patients do much, much better. And looking at by risk group, once again, interface FISH plays a very important prognostic role with these patients. And you can see here that the 11q and 17p deleted patients really do much worse than the other patients. But the other thing to look at, and this is, I think, very important, is when you look at survival by age for patients over the age of 65, and the truth of the matter is I can't distinguish these two colors, so I'm assuming that all of you can. And what we really see here is that the patients who were over the age of 65 treated with FCR actually didn't do as well as the patients who were treated with other therapy. So what can we do for these patients in general to improve their long-term survival? So FCR is the king, but there are a lot of patients that we can't treat with FCR therapy. What combinations and what other agents are we able to do? So the first question is what is the role of adding an anti-CD20 antibody to chemotherapy regimens? And we have two very important studies with fludarabine-based chemotherapy. We have not really a study, but we have a comparison of two phase 2 studies using the CLGB database. These were studies that had very similar eligibility criteria and very similar treatment protocols. And so when we look at the CLGB 9011 study and compare that to the CLGB 9712, so they were studies initiated approximately 7 years apart in untreated patients with fludarabine and fludarabine Rituxan, the two regimens, you can certainly see a marked improvement in the 2-year progression-free survival with FR compared to just fludarabine as a single agent. So this would be the benefit added by by Rituxan to fludarabine. And when you look at overall survival, we also see a benefit there as well. And ostensibly, a lot of these patients who had gotten fludarabine were then able to get Rituxan subsequently as a single agent. So clearly there's a benefit of having concomitant therapy instead of having subsequent therapy as a single agent. And then, of course, the German CLL8 study, which looked at fludarabine cyclophosphamide versus fludarabine cyclophosphamide and Rituxan. Excuse me. And this is the study that led to the approval of Rituxan in combination with chemotherapy for untreated CLL in 2010. And I think many of us have been using Rituxan in combination with our chemotherapy long before that, but this certainly was what finally obtained the approval. So looking at untreated patients with no age restriction but active CLL requiring therapy, they're randomized to 6 cycles of FC or FCR, and you can see the doses here. And there are always a little bit of differences in the cyclophosphamide dose and the fludarabine dose, but I don't think those are really of any significance. The primary endpoint was progression-free survival. And when you look at the outcomes in these patients, you can see that the median progression-free survival was 51.8 months compared to 32.8 months for fludarabine plus cyclophosphamide compared to fludarabine cyclophosphamide Rituxan. Increases in overall response rate, CR rate, as well as overall survival. So here we really see that there's a very significant benefit to patients, and very important to note that this is in association with an overall survival benefit when we add Rituxan to fludarabine cyclophosphamide. And then what about Bendamustine when we add that? So we had remarked on earlier that Bendamustine's approval is really based upon Bendamustine as a single agent in untreated CLL based upon the data I'm showing you here head-to-head with Chlorambucil. And you can see Bendamustine has a median PFS of 21.6 months and Chlorambucil just 8.3 months. So remembering that 21.6 months, when we all of a sudden look at Bendamustine plus Rituxan, we actually see, and you can see the doses here of Rituxan sort of borrowing from the FCR regimen of 375 milligrams per meter squared cycle 1, and then escalating to 500 milligrams per meter squared for cycles 2 through 6. We can see a median, and this is an event-free survival, which is very close to the PFS, of 33.9 months. So there certainly is a marked improvement with just the addition of Rituxan. And what I think is really interesting and important to keep in mind is that this is an improvement far better than what we would ever expect with the single-agent Rituxan. So there really does suggest that there's more of a synergistic than an additive benefit here. So really, with the addition of monoclonal antibodies to chemotherapy, we really can make chemotherapy more efficacious, and we can really actually get very long responses to our patients. And this is very important. So when we start talking about, as the title of the talk is supposed to be on, sort of the benefits of combined chemoimmunotherapy or combined chemotherapy regimens, really, and the utility in this day and age. So yes, they are very effective, but they really come at a cost. And we're all very familiar with the costs, both short-term and long-term. And I really wanted to give another mention to the long-term toxicities that really are the most worrisome for us as physicians, which is really the development of secondary MDS and AML, what is referred to here as treatment-related myeloid neoplasia. And I actually talked to all my patients. Everyone's, of course, heard about Robin Roberts, and that's a very familiar figure here in New York City. She's a Good Morning America host who developed MDS after receiving treatment for breast cancer. And she received very publicly an allogeneic transplant from her sister. So, everyone's very familiar with that. And I think what people have a hard time understanding is MDS after breast cancer therapy is incredibly rare. But it's not so incredibly rare after our fludarabine-based chemotherapy regimens in CLL. And it's really a combination of fludarabine and cyclophosphamide that really plays an important role. And this is data from Mitch Smith. And we really need to have this data updated because the crude incidence here is really being reported out at 5 to 7 years. And really, we would expect the MDS rate to actually start increasing once you get beyond the 5 to 7 year mark. What I'd like to point out that we certainly saw an increase in the fludarabine cyclophosphamide patients compared to the fludarabine patients. And a very significant number of these patients had never gotten a second-line therapy. So it really is the FC by itself that was the responsible agent here. And of course, one of the things that sort of limits, and this is the exact same story that's true for our Richter syndromes in our patients, The number of patients I have on the original phase 1 idelalisib and ibrutinib studies who've developed MDS is quite high. And this is often because they've received, 5 to 10 years of chemotherapies before they went on to these kinase inhibitor studies. They're alive because of the kinase inhibitors, and of course the issue becomes all that prior chemotherapy now is able to demonstrate its toxicities by the patient still being here. And likewise, we have a lot of patients developing Richters on these kinase inhibitor studies, I think predominantly because they're surviving their CLL, and that now it's time to do what we can to avoid these secondary toxicities that are really problematic. And I think that this is going to be an important question to look at because this is just one line of therapy. When we start adding patients who relapse after FCR to get BR, and then we start adding other agents on top of that, it really becomes a very difficult thing for us to envision a long-term survival for our patients. So I'd like now to move on to ibrutinib combinations, which I think, as we heard earlier from Jen speaking about idelalisib combinations, but the idelalisib and ibrutinib combinations really are going to be able to afford our patients what we need to truly make CLL a chronic disease. And I always love to cite the example that no one's afraid taking a pill a day for their high blood pressure. And I'd love it that we could one day have similar evidence to say for our CLL patients that they can take a pill a day and not have to worry about their CLL. So looking at the pivotal study, the ibrutinib ofatumumab study here, you can see, and I showed these data earlier, a response rate of 63%, which includes the PR with lymphocytosis as well as the PR patients, and then a 32% stable disease. So that's sort of our baseline responses. And the question, of course, is the response going to be the important endpoint? Are we talking about, when we look at these data here, what's going to be most important to the patients? And I think it's important to keep in mind is that we really just have response data now, but progression-free survival and overall survival really are what matters. And as I mentioned, the responses are going to be evolving over time such that the response in another 2 years is going to look very different than what it is here. So here you could see the overall survival data for the RESONATE study. And it is interesting to note, even though there was a crossover that happened starting about here, there was a difference in overall survival. And perhaps that difference would have been a lot greater if there wasn't for the crossover. But it does certainly demonstrate the importance of getting good disease control quickly. And one of the caveats, of course, is whether or not the kinase inhibitors, because they do allow sort of the slow time to complete resolution of the disease. And as I mentioned, patients achieving CRs at year 4, whether or not that's something that we need to be concerned about, and whether or not that would be the justification for adding a second agent on top that could take advantage of the cells being driven out of their niches, out of the environments that really protect them. Oh my God. So looking at the ibrutinib combination data, the study actually is what's called the 1108 study, and this really looked at ibrutinib in combination with bendamustine, rituximab, and FCR. And you can see here the treatment was ibrutinib at 420 milligrams daily, and then bendamustine using a dose of 70 milligrams per meter squared. And the dose of bendamustine is always sort of a moving target, and it was combined with rituximab at the standard dosing that we use with FCR, and was administered for 6 cycles. And you can see the FCR dosing that was used here. The huge caveat is that the enrollment in the FCR arm was halted early on due to poor accrual. So this was not a randomized study, but a physician-chosen basis, but also because patients to get the fludarabine needed to be fludarabine naive, and it was sort of hard to have fludarabine-eligible patients who didn't get fludarabine up front. And when we look over here at the patient characteristics, you could see that the characteristics were what we would expect in general. There was a significant number of bulky disease patients, significant number of prior treatments, and the median age was actually a little bit younger than we might otherwise expect, really indicative of sort of a bias that we might see with chemotherapy trials. I would like to actually mention specifically the prognostic markers. So here we are in the Ibrutinib BR group, and remember the numbers here, of course, are very small. And that's why we didn't see any interface fish abnormalities here, because this arm was discontinued. But you could see here that the deletion 11q and 17p numbers are actually quite high, upwards of almost half the patients, really being indicative of what we expect in a very hard-to-treat population. And so the other big question that we have to always remark on when we start combining therapies is whether or not the second therapy is going to interfere with our ability to deliver the first therapy, with the first therapy being the one that we think is doing the heavy lifting. So we always want to make sure we never interfere with that. And what I'd like to point out is that with this combination, we actually had, the median number of courses administered for bendamustine and rituximab was actually 6, though there were some patients who only achieved 2. And the ibrutinib was delivered at 97% of the planned doses. And you can see here that only 7 patients required a dose modification for the bendamustine, which is probably consistent with what we would expect for this patient population as a relapsed patient population. And looking at how the tolerability was, you can see here that the tolerability for what we saw in the combination was probably the same of what we would expect to see with a chemotherapy-induced trial. I do want to say, though, it does look like, and I do believe this, that the diarrhea and nausea is probably greater for the combination of bendamustine plus ibrutinib than what we would see with either agent alone. And what we do see is that the bendamustine plus rituximab actually markedly diminished the lymphocytosis that was seen. So here you could see in the original study the lymphocytosis that was seen, and here it's the lymphadenopathy. I'm sorry, this is a lymphocytosis here with the ibrutinib as a single agent, and here's the ibrutinib plus bendamustine rituximab. Here are the lymph node responses for both agents. So you can see here very nice, dramatic, and deeper drop in lymph node size and the sum of the product of the dimensions with the combination compared to the ibrutinib as a single agent. And you can see here that this lymphocytosis that we see actually is totally ameliorated with the combination of the two. Of course, this we know to really be of no consequence. And what ultimately is going to be a question is whether or not this is also of any consequence. So certainly the quicker time to minimal disease sort of affords an idea that there might be a benefit to diminishing the risk of basically resistance developing. If we assume that the resistance that develops relates to not necessarily pre-existing disease, but relates to the cells hanging around being able to survive and then be able to mutate and develop the resistance, certainly getting them down to a minimal amount of cell counts early on is the most important. The flip side, of course, is that if the mutation that allows the cells to be resistant exists at the time we start therapy, then we're dealing with the situation of maybe having a different therapy that works through a different mechanism may actually knock out those cells. So those are the two questions I think that are going to play out most importantly long term. Now, looking at the best response here, you could see that the response rate for the ibrutinib plus bendamustine, remember we don't have the fludarabine end, was actually 93%, with 13 patients having a CR and 80% having a PR. And so, of course, the PR with lymphocytosis arm really went away. So this is hopefully with really just 3% here in the nodal arm. So it's really sort of interesting to suggest that maybe our response rates that we can see with ibrutinib long-term might reflect this, but this is the way that we can get these responses very quickly. All right, now I didn't realize I had that in as a animation, but you can see historically the bendamustine overall response rate, for bendamustine rituximab overall response rate is 59% with 9 CRs for comparison purposes here. So clearly the ibrutinib does add to the bendamustine rituximab even in the acute part of the treatment. So in conclusion, combination chemotherapy works better than single agent, but once again, the question is, what is the data, what's the most important endpoint that we want for these data? So the data for chemoimmunotherapy is going to be based on overall response rate and PFS, and the data for kinase inhibitors is actually going to be overall response rate which is still evolving over time. So these are the very important questions that we can't answer here, but at least at the data that we have now, we definitely see marked improvements in overall response rate. Additional toxicities are seen with the combinations, but they are mostly manageable. And I do believe that as people get more experience, we'll start learning about better ways to manage a lot of these toxicities. And the question that we'll never be able to answer is whether or not there's a need, because certainly it's going to be a situation where hopefully these patients do so well for so long that it's a trial that would just take forever to meet its endpoint. Thank you.